Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. Today I'm going to talk to you about CONTRAVE, naltrexone bupropion. There's no generic. It is a weight management medication, a combination medication that contains an opioid antagonist, naltrexone, it blocks opiate receptors, combined with a norepinephrine dopamine reuptake inhibitor, bupropion, also known as Wellbutrin. It's FDA approved for chronic weight management and specifically as an adjunct to a quote-unquote reduced calorie diet and increased physical activity. So there is that caveat that you should be dieting, restricting your calories, and exercising. Also, it is only officially approved in adults with an initial BMI, body mass index, of at least 30 kilograms per square meter, the definition of obese, or alternately at least 27 kilograms per meter squared, which is significantly overweight. The cutoff there is actually 25, in the presence of at least one weight-related comorbid condition, like hypertension or diabetes. Bupropion increases dopamine and norepinephrine by blocking both the dopamine and norepinephrine transporters, i.e. the reuptake pumps. And blocking reuptake by the neuron that released them increases the concentrations of both catecholamine neurotransmitters at the synapse, the gap between neurons where communication takes place, conferring the medication's antidepressant action. It also, by increasing those neurotransmitters, dopamine and norepinephrine, it's dopaminergic and noradrenergic. Wellbutrin also improves concentration independently of its effect on the mood, as well as increasing the libido in a lot of patients and curbing nicotine cravings in some others, among other psychotropic actions. It is FDA approved all by itself, and it's called Zyban, to treat nicotine dependency or nicotine withdrawal. Nicotine use disorder. Nicotine use disorder, that's the current parlance. In the hypothalamus, however, these two neurotransmitters activate propiomelanocortin neurons. Propiomelanocortin. And these neurons release propiomelanocortin, which is then broken down into alpha melanocyte stimulating hormone, which in turn binds to melanocortin 4 receptors in the hypothalamus. And what that does is it suppresses the appetite. So it is an appetite suppressive pathway in the hypothalamus that is activated by dopamine and norepinephrine, but that's the cascade via propiomelanocortin neurons. However, the brain is always wanting to maintain a homeostasis, so stimulation of propiomelanocortin neurons also activates an endogenous opioid-mediated negative feedback loop, which mitigates the appetite-suppressing effects. Okay, so it's a negative feedback loop. So endogenous opioids, endorphins and enkephalins and such, acting on those neurons at opioid receptors, puts the brake on propiomelanocortin and alpha melanocyte stimulating hormone. Naltrexone, however, blocks mu opioid receptors, thus preventing this opioid-mediated negative feedback. And so combining it with Wellbutrin results in a more robust and long-lasting appetite suppression due to activation of the appetite-suppressing pathway by bupropion. And it's more robust and it lasts longer, it's more significant than with either drug alone. Each drug alone can cause appetite suppression, but in actual practice, Wellbutrin is a weight-neutral medication. It certainly doesn't cause weight gain, and that's an advantage. But whatever appetite-suppressing properties it has are quickly suppressed by endogenous opiates. I've prescribed Wellbutrin tens of thousands of times throughout my career, and I've taken it myself, and there was never any substantial weight loss to speak of, really. CONTRAVE is usually dosed twice a day, 16 milligrams of naltrexone with 180 milligrams of bupropion twice a day. That's the maximum dose. But since it's only supplied in 8 and 90 milligrams extended release tablets, you end up taking 2 pills twice a day, following a month-long titration that begins with a single tablet in the morning and which gradually reaches the maximum recommended dose. The instructions are to discontinue the medication if at least 5% weight loss isn't achieved by 12 weeks on that dosage, that maximum dose of 16 milligrams and 180 milligrams twice a day. The tablets shouldn't be divided or crushed because of the extended release property. They can be taken with food, but care should be taken not to dose with a high-fat meal, because taking the medication with a fatty meal may increase bupropion and naltrexone's systemic exposure outside of the central nervous system. We want them at the hypothalamus. Also, importantly, patients must be completely withdrawn and abstinent from opioids for 5 to 7 days, or in some cases 10 days, depending on the half-life of the opiate in question, in order to avoid precipitating acute withdrawal by naloxone. If you add naloxone to someone who is actively taking opiates, suddenly those opiates are going to be blocked, and if it's a significant dose, the person is going to go into withdrawal, which isn't dangerous, but which can be agonizing. Patients who require opioid treatment from time to time should temporarily discontinue CONTRAVE. And if that's the case, they also need to be counseled that they might need significantly lower doses of opioids, because in the presence of an opioid antagonist, the body will upregulate those receptors. So if you take CONTRAVE long enough, your body's going to try to achieve homeostasis. You're blocking all of these endogenous opiates from binding to their receptors, so the body's going to make more of those receptors. And that means that you could be exquisitely sensitive to the next exogenous dose of hydrocodone or oxycodone or morphine or whatever the case may be. If you're shooting heroin, you could overdose on it if you've been taking CONTRAVE and you stop. The body always tries to maintain homeostasis. That's why there are negative feedback loops as well. And so the individual is just more sensitive to the presence of an opioid because there are more receptors. CONTRAVE has been evaluated in controlled studies up to 56 weeks. There's no short-term treatment caveat that you sometimes see from the FDA. Sometimes the FDA says it's approved for short-term treatment, and that usually means a few days or a few weeks. But this medication is actually approved for not so much weight loss, even though that's the effect you're going for, but for quote-unquote weight management. Again, as part of a lifestyle change that includes nutrition and exercise. It's not habit forming, but tapering is prudent when you want to stop if the dose is significant, mainly because of naltrexone's effects on the body's opioid receptors. Bupropion can be safely discontinued without weaning it, but in theory, you could see a rebound depression or difficulties concentrating or lethargy or amotivation, depending on the underlying condition. But unless a person is experiencing a major depressive episode, an active episode of acute depression, and they haven't been on the antidepressant long enough, and you stop it, those patients might actually rebound back into depression because you stopped it too soon. But otherwise, most of those rebound symptoms, if present at all, would self-correct in a matter of days for most patients. So it just depends on what the dose is. I usually do not wean Wellbutrin. If I'm working with a patient and that medication is not serving us and we need to change it, move to something else, for whatever reason, if they're not tolerating it or if it's just not giving us what we want, then I don't tell them to lower the dose slowly. I just switch them to the next thing. Or if we're not going to replace it with anything, we just hold it. Side effects are fairly nonspecific. The usual suspects: nausea, vomiting, constipation, diarrhea, dry mouth, headaches, dizziness, insomnia. Most medications can cause any of the above, really. Potentially life-threatening or dangerous side effects include increased blood pressure or heart rate due to increased norepinephrine from the bupropion, especially in vulnerable populations, for example, an elderly person with pre-existing cardiovascular disease. The norepinephrine causes vasoconstriction in the periphery, and that increases peripheral vascular resistance, which increases the blood pressure. It also increases the pulse directly by acting directly on cardiac muscle. And all of these cardiovascular effects and the concern is especially true during the first 3 months of treatment. So that's when you really want to get a baseline blood pressure and pulse and monitor it at the beginning and anytime you increase the dosage. Rare seizures are possible, again, due to bupropion, but not usually at therapeutic doses. You're more likely to see seizures in overdose or for certain patients with predisposing factors, such as epilepsy, and especially poorly controlled epilepsy. That would actually be a relative contraindication. If you have a patient who has epilepsy and it's poorly controlled, that patient should not receive Wellbutrin or any medication that lowers the seizure threshold until you get that condition under control. There is a related concern about seizures in patients with a history of eating disorders, bulimia and anorexia nervosa specifically. But really the seizures that were seen were in underweight, anorexic individuals, and they were on high doses of the immediate release preparation. So as far as I'm concerned, if a person is of normal weight and they're not actively purging, and there's no reason to suspect an electrolyte disturbance or a lowered seizure threshold for any other reason, and they're taking the medication responsibly, and especially if you have a patient with those eating disorders, I would definitely use the extended release preparation. I might not go above 300 milligrams at one time, although the current standard is up to 450 milligrams of the XR preparation. There are actually preparations that have 500 milligram doses, but they are specially formulated. And they're new and they're super expensive. But I think even the relative contraindication there can be managed. There can also be the rare activation of suicidal ideations, putatively, and behavior. It has been seen, but really it's chiefly seen in young, impulsive patients on antidepressants, especially those with a history of suicidality. Short-term studies didn't show this association beyond the age of 24. And so the FDA's black box warning is for individuals who are younger than 24 years of age. But again, in my opinion, especially those that are impulsive and that have a history of self-injurious behavior or of suicidal ideations, I side with the clinicians who consider the FDA's blanket black box warning for almost all antidepressants of every class a bit of an overreaction. In 30 years, I've rarely seen a patient react paradoxically like that. And the few that I can recall were intermittently suicidal to begin with, so there was really no proof that it was even the medicine in those instances. You should always be mindful of the possibility of suicidal ideations, especially as you begin treatment with any patient who's depressed, and you really need to rule out that concern. But in a patient who's never been suicidal and who's either mature for their age or in their 30s, you just don't worry about it. Contraindications include uncontrolled hypertension, as well as poorly controlled epilepsy, pregnancy as well, and bulimia or anorexia. Maybe those are relative contraindications in my book. If a patient is abruptly discontinuing alcohol, a sedative, an anticonvulsant, or any other medication that raises the seizure threshold so that by discontinuing it, you are actually risking a seizure, you want to be very careful. It's all relating to the fact that you can get seizures with too much Wellbutrin. But again, you would almost have to be dosing it irresponsibly or taking it irresponsibly. If a patient is taking opioid analgesics to avoid precipitating or exacerbating withdrawal, you should not combine with CONTRAVE. Also, this medication is not to be used with MAO inhibitors, monoamine oxidase inhibitors. There is a risk of hypertensive crisis, and so you actually have to wait a full 2 weeks after stopping an MAOI before you can start a medication like this, because the monoamine oxidase enzyme is inhibited irreversibly, and the body has to make more of that enzyme before the effect of those medications leaves your system. So it's at least 2 weeks. There are a lot of drug-drug interactions, unfortunately. Those are beyond the scope of this presentation, but practitioners, be aware of that. CONTRAVE can block the effects of opioid-containing medications, so some cough and cold remedies, antidiarrheal preparations such as Imodium, and opioid analgesics. They may not work if you're also taking CONTRAVE, and that should be taken into consideration. How much weight loss can you hope to achieve with this medication? It's not Wegovy, okay, and it's not Mounjaro. Benefits are modest. Patients may hope to achieve 5 to 10% reduction from baseline in body weight. which may also take several months. And if a patient has lost weight on either active compound alone, they may experience a more robust weight loss with the combination, a synergy with those. There are no head-to-head studies that have been conducted with other drugs approved for weight management, such as Qsymia, yeah? So comparative efficacy to those agents is unknown. I just did a video on Qsymia, which is phentermine topiramate. Please check that one out. It has the same FDA approvals, the same wording, same caveats, but they also have a juvenile indication. So that's it. Please look out for that video as well, and thank you for watching.